Good afternoon, ladies and gentlemen who have joined us on this Dr. Fundi channel via multiple social media platforms, via YouTube, via Facebook, via Instagram, and also those who have joined us via Zoom. We have a very interesting, conversation in prospect with our special guest today. As you know, on Sundays, we have a feature that we call a Salute Sunday feature. That's a feature when we choose one South African who is doing great things in their chosen area or chosen profession or chosen area of endeavor. We've featured quite a number of people who are doing different things, great things. So today, we are featuring Dr. Mmuso Mogwera, Dr. Mmuso Mogwera, but I like the way he puts his name on Facebook. He says, Mutlutlegi Tautuna Mmuso Khosi Mogwera. Now, that's a mouthful. You know, it reminds me of the former leader of Moputatswana. Mutlutlegi Tautuna Mangope, all right? And the person that we are interviewing today actually comes from the Northwest, the former Moputatswana area. So I'm not surprised, that he refers himself to Mutlutlegi, which is honorable. Tautuna, Tautuna is the great lion. It's the great lion, it's the boss of lions, basically. Mmuso Khosi Mogwera. Now, a little bit about him. He's a young super achiever who hails from Mukoka in Northwest, all right? When I used to go to Limpopo, I would be surprised. Every village, it starts with Kha, this, Kha Ramukopa, Kha Matlala, Kha this. So I didn't know that even in Northwest, the villages, they start with Kha. So he comes from Kha Ramukoka in Northwest. He's a specialist physician and also a subspecialist in cardiology. He practices medicine in the Rustenburg area. Okay. Now, a little bit about his education. He studied his undergraduate MBCHB degree at Medunsa, or what other people call Sefako Makgato University, or others they refer to it as University of Limpopo. And then after doing his internship and his community service, he decided to go to Wits University, swapping Roslyn with Parktown, where he then went to do his postgraduate, training, where he then, managed to get an MMed, all right? So that's when he became a physician. And also, he passed his fellowship exams from the colleges of medicine of South Africa. So he's got double qualification, as a specialist physician, but he was not done. He felt that he needed to do more. And so he decided to, take on the subspecialty of cardiology, which is another 2 years, if I'm not mistaken, before you get the certificate. So this guy has been studying 6 years of medicine, 1 year internship, 2 years of ComServe, I don't know how many other years, 4 years of specialist physician, 2 years of cardiology. So he just loves books. But anyway, he is now the head of cardiology services at the Bujanala district in Northwest, where he works in a public-private partnership with their local private hospital, delivering cardiology services, and is very passionate about delivery of high-quality healthcare services to patients, both in rural and marginalized communities, and also the affluent communities. But he's got a soft heart for those who come from the underserved areas. He says he is a dedicated teacher who, after teaching his his juniors, they often are left in awe of the depth and the breadth of knowledge. And his knowledge is not just limited to cardiology. And I can actually attest to that, as his Facebook friend. I actually see a lot of knowledge beyond even internal medicine and cardiology. So this is a man who's very broad in terms of his knowledge. And he says he's also an academic at heart, currently supervising retrospective studies in his field of interest. And also he is involved in a number of clinical trials. So that makes him what we normally refer to as a clinician scientist, because one part of him enjoys being next to the patients, but the other side of him, he is involved in scientific research. He's a man who believes in evidence-based medicine. He doesn't opine, on matters medical if it is stuff that is just from anecdotal stuff. It must be evidence-based, scientific-based. And he's got hopes that one day there will be a specialized cardiac unit in the Bojanala district that will provide a range of cardiology services, including heart transplants, making it accessible to people irrespective of their socioeconomic status. That's in line with the NHI that is supposed to come in the next few years. Just some nice tidbits about him. He is a fun-loving guy, I must say that. He is sometimes controversial and very opinionated, but you would expect that from a Pirates fan. So he's an Orlando Pirates fan. He loves his soccer. And when he was at Medunsa, he used to play for Juventus FC. I'm not sure, whether he was a bench warmer or he was in the first 11 for his team. But anyway, Dr. Mogwera, welcome to Dr. Fundi channel.
Thank you, Dr. Nyati. Allow me to just refer to you as Fundi, because when I say Dr. Nyati, then it will put us on the same level, and I don't think I can be at your level,
Oh, okay.
Yeah.
You can twist your tongue and just say Griecha, like I say in to you, just say Griecha. When I say Fundi, and I was like, hey, I'm very old, yet I'm still very young at heart. People like Bo Ritadile, our common friend. I'm in that age of the early 40s, just by association. So it's okay. You can just say Ngaka or Griecha, so it's okay.
Thanks for the invite. I really appreciate it. I think it's a great opportunity for me. I really appreciate being here. Just to respond to your introduction, my village is actually in the north part of the Northwest. It's actually a border between Limpopo and the Northwest. Okay. It's the furthest. That's why the names are Haramukoka, like that. It uses the names interchangeably. Ramukoka started and Haramukoka, and that's where I grew up. And yes, my names on Facebook, they do relate to the former leader of Bophuthatswana, and it's, for me, I admire some of the good things that the former leader has done, and I think, in my opinion, there's a lot to learn from what he has done. I've never been a bench warmer. Even before I joined Juventus of Medunsa, I've never been a bench warmer. I enjoyed my time there by Roslin, and I enjoyed my time in Juventus.
Yeah. So, what position do you play?
So I'm a defensive midfielder. That's the position that I'm so comfortable with. And you'll remember at some point we were talking on Facebook, and I referred to what was going on at that time. I said we can learn a lot from defensive midfielders, that at times they never get credit. We give the credit to the strikers, but if you look back and you must check who won the ball and who passed the ball, then you'll understand the role of defensive midfielders in the profession that we are in.
Beautiful, beautiful, Doc. So, Doc, let's get on, how we're going to go about this thing. will trace just your journey up to medical school, up, to when you became a cardiologist. And then we will then focus on the two issues that I thought you should help us just to have a better understanding on, which is COVID-19 and heart-related manifestations, as well as the issue of some of the adverse effects relating to the Pfizer vaccine. So we'll have a little bit of some information sharing there, and a lot of people are looking forward to that. And then towards the end, I'll come back and ask you questions relating to what's next for you. You've achieved so much. Just let's clear this one. Doc, there is the latest age of vaccination that was introduced about 2 weeks ago. Have you reached that age, Doc?
I've reached that age. I've reached that age, Doc.
Okay.
I've just made it.
Okay. All right. No. Thank you for clarifying that, because people are saying Ben 10 of the nation and all of that. Others think you skipped some classes. So at least you are in the vaccinable age. Then at least you are not so young. All right, Doc. So can you just tell us a little bit about the village you came from, especially the family? Are you the last born, middle born, first born, and what kind of things, values that were instilled in you that have become your compass as you've been, going through your life to date?
Thank you. As I said, I come from a very small village, Ramgogastad, dusty roads, even now, dusty roads. Just on the north side of Mogwera, that's the north side of Sun City.
Yeah.
I'm the last born of the four. I have a sister and 2 brothers. I grew up in a family where we were taught only one thing, that the only way out of poverty is that you must seek knowledge, and the only way you're going to be knowledgeable is for you to get educated. My parents, both parents were teachers. They are now pensioners. In fact, my mom taught me in grade 5 and I think grade 5 and grade 6. My mom taught me maths in grade 5 and grade 6. So I was in the same school where she was. So when I got naughty, others, they would only be punished at school, but my punishment will be double, because when I get home, then my dad get told of what I did at school.
Yeah.
I was taught that I'm a member of the community. I cannot detach myself from my community. And the saying that says charity begins at home, it was instilled in me to say that when we say home, we mean this community. You need to make sure that if you ever get to achieve something, your community, you should pull it with you, and they should be proud of what you have done in life. So
lift as you rise kind of thing.
Yes. So that's the community that I have. But having said that, also, it's a community where it was almost difficult to find a role model in there, unless you are in a family where there are role models in there. And I mean, to mention, a few, while I was growing up, I would meet some people who would come and visit my dad. And the one that I remember very well is the late Judge Busielo, and at that time, all I, as a young man, all I wanted is to drive his beautiful BMW. And the answer that I got from him and my dad, they said, you need to go to school. If you go to school and you pass, this is achievable in it. And I since then, I managed to follow his career until his passing. And I realized that coming from a village to becoming a judge of the appeal court, it's doable. And those are the things that I could pick up. And Like I said, it was a normal thing
Yeah.
to read at home. You were forced to read.
And that could that be the reason why you're driving an M Sport BMW now?
It might have influence. You'll never know what kind of influence you can make in young people's decision making.
Yeah, okay, all right. So, but now let's get back to your mom and dad. Besides them making you to be socially conscious, and belong to that, community and identify with the community. But as parents, what other things, did they teach you, which are still guiding you today?
I think the most important thing was discipline. They taught me that you can be talented, but talent without discipline, it will be useless.
Mm,
You need to have your principles. You need to set your goals, and the only way you will reach the goals is by being disciplined. And they taught me one important thing to say: you must adapt to times. To
mm,
say the goal does not change, but how to get to the goal, you might have to change the paths during the times. As the times change, you might have to adapt there and try to see how you get to your goal. But you set your goal, you get disciplined, and you reach your goal, and that's what you need to do.
Beautiful, beautiful. So, as the last born of the family, would I be right to say maybe you may be displaying some, last born tendencies, or actually, you're one of those last borns who actually behave like middle borns, who go getters, who don't, have to wait for approval for anything. Go make things happen, because the firstborns and the lastborns generally they tend to take things, for granted. But how would you describe yourself?
Look, I've always been a playful person, at
Yeah,
times very naughty,
yeah,
but I'm self-driven.
yes,
That's another thing. I'm self-driven. I've always been a go-getter, and I'm always curious to say, how do I get there? What can I change in my life to get to such things?
yes,
So I wouldn't say that I display the stereotypical last-born tendencies of
yeah,
waiting for everything to be given to you and everything.
yeah,
I push, and I believe in pushing the boundaries.
yes. That's lovely. That's lovely, talk. All right. So, quickly, junior and secondary school. Any highlights there before we get to the varsity?
But I think the primary school was great. It was in the village. I mean,
Yeah,
that was great. Nothing really wow, but it was a normal
yeah,
life of a village boy. Then my secondary schools, I was in a boarding school
yeah.
from from grade 9. Yeah, that was awesome. That was awesome.
Was that a Model C school? Because when I looked at the name, it looked like a Model C school, doc.
You can call it that. You can call it that. It was a boarding school somewhere in the east of Pretoria.
Yeah.
That's where my parents sent me, but I think I was just too hyperactive for them, so they decided to ship me out of town to just stay there. You
Okay,
know.
beautiful, beautiful. All right. So, at what point then did you decide, you know what, I actually want to follow the medical route? I want to study medicine. Obviously, you have to apply before you finish your secondary education. So, when did you decide that, this is what I want to do?
I, Look, I made this decision. I think I was doing grade 11. I had three options at that time. I think it was medicine and pharmacy and also engineering. I
Mm.
wanted to do metallurgy.
Mm.
Then, I think the final decision I made it after getting my results.
Is it?
So I
So,
had
you
applied
applied
for,
to all of these things.
yes, I applied all of those. I applied all of those. Then after getting my results, and I I had to sit down and say, what exactly do I want to do? And I was accepted, I think, at UJ for metallurgy, then at Medunsa for medicine. Then maybe I was scared of Joburg. Then I thought of Garankuwa because it was closer to home.
Yeah.
Then I decided to do medicine.
Yeah. Okay. But metallurgy, I mean, coming from the platinum province, could have been relevant there as well, because
Yes.
you guys, that part of the world, there's so much of mining that is being done there, so you wouldn't have been lost. But I think the medical profession has actually gained with you choosing to do medicine. So you decided to go to Garankuwa. And how did you find, Musa when you got there?
It felt home. It felt at home because then the culture at Medunsa it's more of a village culture thing. So for me, it was a normal thing. I had a great 6 years, and I think I made more friends at Medunsa than anywhere else. Even now, those are the friends that I still hang out with, and it was a great 6 years. I really enjoyed my 6 years at Medunsa. Even when I look back and say, would I have changed something if I was given an opportunity to spend 6 years there? No, I would still have stayed at Medusa for 6 years. It was a great time for me.
Yeah. And that's the time where you were a team member of the Juventus FC. Now there is a Dr. Luvuyo Bayeni from the Eastern Cape who says his team, Arsenal FC, they used to beat you guys up, many, many a times. I'm not sure. I mean, is that a correct recollection of events?
No, I think one thing that you must understand is that Levuyo works as a spin doctor for the department somewhere in the Eastern Cape. So there might be some information that is false in there. I would say to you that this is comparable to Baroka and Orlando Pirates situation where someone just came into the league. So Arsenal FC had just gained promotion into the league, and few games, yes, once in a while they will beat us, but I think most of the time Juventus came out in the upper hand. And I mean, Juventus is now, I think, 20 years now, and still going strong. Is still there. It still exists. So it's a good legacy for many of us.
Yeah. Okay, Doc. So in your 6 years there, did you have any particular discipline of medicine that you fell in love with? Or you one of the guys who, even after qualifying, they were not yet sure, which of the disciplines do I want to be in surgery, or do I want to be in internal medicine, peds, gynae, So did you have any particular discipline that you liked at the time, or you only made up your mind afterwards?
I must say, I enjoyed neurology and I enjoyed internal medicine, but at that time I had not decided that I'm going to be a physician. It was a matter of I just enjoyed it. I found them easier as compared to other disciplines. That's the thing.
Okay. All right. So you went out, okay, when you got your MPCHB, what did it mean to you? What did it mean to your family?
Sure. Yeah, I think I think at that point it meant a lot, and to my family, I think it was the greatest moment.
A young man from Garamakoka,
Yes, a young man from Haramukoka start where there's no doctor who comes out of that village, and becoming one of, if not the first to come out of that village, the first in the family to be a doctor. So it meant a lot for my parents, and at that time they were approaching their pension years. They were in their getting to their 60s. So it was a beautiful moment, and for me it was the moment where I realized that everything is possible. Then I was I had to think about what's next at that moment,
Yeah. And it also signaled to your parents the end of having to pay, tertiary school fees.
Yes.
It was you being the last born. You were the
Yes.
last one, and it was now your turn for black tax, to go the other way around. Although as teachers, obviously they've got relatively good, pension. All right. So, Doc, where did you do your internship?
So I did my internship at Kalafong in Atteridgeville.
Hmm.
I think 2009, 2010. That's when I was at Kalafong at Atteridgeville.
Yes. And then your ComServe?
My ComServe, that was a great time. Also, I was at Potchefstroom. I think that's the year that I made most of my decision, and I really enjoyed every moment at that time. And I think that shaped me a lot and made me change how I think. And because I was coming from Kalafong as an intern where it was easy to access everything. You needed a CT scan, it was just there. You needed an MRI, you just call Steve Biko, you get it. Everything was just close by, everyone was referring to you. But I got to Potchefstroom where you had to refer most of your patients into Joburg. And that's where I understood the frustration of the referring doctor when he's sitting 200 kilometers from the next hospital trying to get the patient to the other side. But of importance is that the guidance that I got during that ComServe, I mean, there's something special about what was happening in that Potchefstroom hospital. The hospital had two permanent internal medicine consultant. It was Dr. Musa and Prof. Mukobo, the cardiologist.
Yeah.
Without fail, these two gentlemen, they would be in hospital every day. They would do a ward round every day. And that changed my thinking about what it means to be a consultant. It also changed my thinking about what it means to supervise the junior. And that's where I developed my love for internal medicine and my love for cardiology, because you wouldn't struggle to get help with an ECG if you can get hold of Prof. Mukobo. You meet him in the passage, he would help you to interpret an ECG within a minute. And I think at that time, I learned a lot of skills in Potchefstroom. I was supposed to rotate in 4 months in gynae, 4 months in internal medicine, 4 months in casualty. But during that time, I made after the first 4 months in internal medicine, I made a request to the clinical manager. I spent 12 months in internal medicine. And
wow.
Yeah, that's where I really enjoyed being a doctor and a junior doctor, because then you had all the support.
You know what you've just said, it's so interesting, Doc, because most guys, when they come out of med school and they have to choose where to do internship and obviously later they would have a preference of a big hospital, like let's say even a Kalafong, where everything is available. But actually, there's a school of thought that says when you go to outlying areas, you tend to learn more and take more responsibility than in areas where you've got all these layers, of people that are supervising you. And it sounds like at Poch, you actually got a lot of practical experience, and obviously, the prof, who was also a cardiologist, had a lot of influence in you.
Yes, first, I think we must clarify one thing. I think the layers are very important.
Yes.
The layers that you find in academic institutions, they are very important. But what's also important is the supervision, the availability of the senior doctors. And even when they are not available on site at that point, their availability over the phone. But yes, the Prof. Mukobo really played an important role, because then it was exciting to look at him interpreting an ECG while you are struggling, he would just take a minute and he would give you a diagnosis. You know, it was exciting to see how he would just take an echo probe and make a diagnosis, and we've been struggling with the diagnosis. So his influence, and when we looked and I asked around, and you were told that he's one of the first Black cardiologists in the country, and he said, all you wanted to be is to be like him. You say, how can someone make so much difference in a community, in a small community like Potchefstroom?
Yeah.
And you just wanted to see if you can get to that level.
Yeah. And, you know, in one of your Facebook posts, Doc, on the 9th of June, 2016, you wrote, I am Prof. Bongani Mayosi and Prof. Mukhobo in the making. 5% loading. Time remaining, I'm still calculating. You know, and I mean, it tells the influence that Prof. Mukhobo had in you, and obviously Bongani as well.
Yes. I think the late Prof. Mayosi, I think he was the epitome of Black excellence, and I think those who got an opportunity to train under him, I think they were very blessed. Even those of us who never trained under him, but following him, we were really encouraged to see what he's doing. And I think I don't know. I think that there is something that he planted in the Eastern Cape, as you can see. I mean, I think if you look, the Eastern Cape is probably has more cardiologists than probably more than any other province in the country, except for Gauteng, maybe. Yeah. But I think these are the two great giants, which if I ever get to perform to their level, I would say mission completed.
Yes. All right, Doc. So you then became you became a reg, you know, when you came back to Joburg now at Vets, and you trained as a reg. I will say something that hopefully will not irritate you. So you were not bullied as a reg.
Except I was bullied as an intern.
Yeah.
But I learned how to deal with the bullies as an intern, and I decided I'm not gonna make that deter me. I had a goal, I knew, and I understand that there are lots of bullies in the academic world, but we should not also promote the ill discipline of junior doctors and calling, and also then they claim that they are bullied. I mean, I laugh about my moments where I was bullied. I mean, there's one also that I like making fun of. It was in 2010, the 11th of June, the World Cup is starting. I think the then president asked us to support the team. And I was in a discipline where you were not allowed to wear a t-shirt, you were not allowed to wear a jean. And it's the 11th of June. Our cars have Bafana flags and everything. So on that morning, I rocked up with Bafana t-shirt. I rocked up with a vuvuzela in support of Bafana and everything. But I kept to it. So I was chased out of
of the world round.
Of the world round. But it's one of those moments, but I didn't take it. So I didn't take it to heart and everything. But I must say that what happens at Vets, I don't think I was bullied at Vets. I enjoyed my time at Vets very much so, and that's why every time I talk about Naturena and Parktown, I'm excited. It was great time at Vets.
Lovely, Doc. So as you were doing your reg to become a specialist physician, were you already at that point then knowing that once you get your FCP, you are going straight pursuing cardiology to be like your prof at Potchefstroom?
Look, when I was a reg, I was not fixated on cardiology. I had two options. I worked, I think on my second rotation at Vets, I worked in hematology. I worked with Professor Musa Patel.
Yeah.
Once again, I learned again, I saw a guy who takes time, who doesn't just see a patient. He would see the patient and he would make the diagnosis, but before the patient walks out, he would chat to the patient and want to know if the patient had something to eat before coming to hospital. Do they have transport money to go back? And I fell in love with that discipline, with the work that they were doing with the limited resource that they had, to a point where my MMed research
Yeah.
was in hematology,
Yeah.
because I loved the work. I loved the work ethic in the department, but also I love the adrenaline in cardiology. The work ethic in cardiology at Bara was also that pushed me to say, these guys, they are so much dedicated to their job. They have so many patients. They are draining almost the entire southwest of Gauteng. They are draining the northwest, but they still go to work as if they have so much resources. They will never have an excuse why they can't open the cath lab and do a rescue PCI. So those are the things. So I was conflicted also, but my last 6 months, I made a decision. I decided I'm going for cardiology.
All right, Doc. I looked at your topic. Your topic was something about autoimmune hemolytic anemia or something like that.
Yes.
What was it all about? Just briefly.
So it was a retrospective study that we were looking at the clinical outcome of the patients treated at Chris Hani Baragwanath Hospital, and they were all in different immunosuppressants, and we were looking at their clinical outcome. So we ran it. It was a 10-year period where we looked at all the files, and it was an interesting outcomes, and it was showing that real work has been done in the department, and what was interesting is that we were able to get the files of almost every patient. I mean, where I couldn't get the file, I would just call the prof, and the prof would say, "No, that's a file of an interesting patient. It is in my locker. Come to my office."
Yeah, beautiful, beautiful. All right. So obviously you got your MMed. Which one came first, the MMed or the FCP?
The FCP came first.
Yeah. Okay.
So I wrote the FCP, then I finished off my MMed.
Okay. All right.
Yes.
And then you then continued with cardiology now, still
Yes.
at Wits.
Yeah. So then I started my 3-year training at Vets Cardiology. Also, it was a great department. We got to work with one of the best in the country. We got to work with the guys who they wouldn't make you feel junior, where using first name was normal. That's why we get surprised when people don't want to be called by first names and everything. First name in the way, sometimes you will even forget your boss's surname because then you are so used to first name. But there was so much training, there was so much supervision during these 3 years. But the mentoring was also very important, because then even when you don't make it through the exam, you knew that you have support, you can still make it on the next exam.
All right. So, Doc, now I want us to get to the issue about COVID-19 disease and its, cardiac manifestations. Whilst we are trying to get yourself ready, anyone who is either following us on Facebook or YouTube, or any of the people who have joined us on the call on Zoom, they can send any questions that Doc Mogwera will be able to answer, later. There's another, post of yours, Doc, where you said one of your teachers from, I think, I think was it at medical school, who said, you are a joker, my boy. The only thing that you are just need to get is the red nose. Where was this?
Oh, Dr. Yati, you can get me.
I have to mention the name of the senior who said that.
No, it was at Roslyn, but it was at Medusa. So, but you see, this is how I look at this thing. I do not think that the teacher meant to hurt me, but maybe it's the way I look at things. So that's why today I laugh about it to say that, I didn't know the answer. And he just said, you're a clown, you're running short of a red nose. And
well, well, I think that was right because I mean that's the person that you are, Doc. But anyway, so since January last year, we've known about this pandemic, COVID-19. It was not called a pandemic at that time. It was, an international disease of interest, something like that. And it's only on the 3rd of March that they actually called it a pandemic, when all the continents now had patients who had been diagnosed with this thing. In South Africa, we had our first case on the 5th of March. And this is now almost 16 months later since we had our first case. A lot of research has happened throughout the world to better understand this thing. At the beginning of the year, I had asked a friend and colleague of yours, Ulebu Patadira, to actually talk to us about the neuropsychiatric manifestations, and he did a great job about that. And so today, I'm asking you to share about the cardiac manifestations of COVID-19. And one of the reasons that triggered this for me is that 10 days ago, I lost a friend that I've known for 40 years since high school. He died of myocarditis relating to COVID. And I thought this is the right opportunity to actually, hear more about this space. So that's really the reason why I threw this in our conversation. So, Doc, how common are manifestations that are heart related on people who are presenting with COVID-19?
I think, Dr. Nyati, the first thing that we must acknowledge is that there's still a lot to learn about COVID, and every day we learn about it, and we learn new presentations about COVID. And we must also acknowledge that although COVID is being presented as a mainly respiratory disease, but we know very well that it's a multi-systemic disease, and one of the commonly affected system is the cardiovascular system. And the presentations and the cardio manifestations are very common, and they range from a simple thing as palpitations and cardiac arrhythmias. And when you're looking at the symptoms, just patients coming in with palpitations, these palpitations, they might be during the acute presentations of COVID. But what's interesting is that even post what I would label acute phase recovery, because I think it's too early for us to even be saying people have recovered from COVID, because we don't know what the cause of the disease will look like in 2 to 3 years. The patients, even after they have recovered from maybe severe COVID pneumonia, 3 to 6 months later, these patients still come in complaining of palpitations, and they still have this persistent, unexplained sinus tachycardia. But coming back to these arrhythmias, it starts from just sinus tachycardia. Some go.
Doc, sorry. Yeah. So where I can, I will just add some layman's things. You know. As you are talking, so sinus tachycardia, that means the heart is beating very, very, very fast, right?
Yeah, it's just beating very fast, inappropriately so, right? Yeah. And you will have with those who come also with life-threatening arrhythmias, where they get ventricular tachycardias. This is seen mainly in patients who are in ICU, and these patients will usually have severe COVID pneumonia, and they will have ventricular tachycardias, which are life-threatening arrhythmias, which need to be treated immediately, or they can lead to death at that time. And as I was discussing one with a friend of mine, to say that we've lost a patient that we thought was recovering, and we think that probably had an arrhythmia. Then you also get things like bradycardia and heart blocks. So these patients, they get heart blocks while they are in ICU. The mechanisms of this arrhythmias is not really well known, but it's postulated that it might be related to what you really wanted to know, the myocarditis. Myocarditis is one of the big ones, which is the presentation that the patients come in with, and these patients, when you do the troponin, which is what we use to measure the muscle injury, the heart muscle injury, they come in, they have a high troponin, which is regarded as a poor prognostic feature in patients with COVID, So these patients, they will come in with that, and they will present either with just chest pains, and some they will come in and even have a fulminant heart failure, and as these patients present, it's always difficult to decide whether is this patient just having severe pneumonia or is it myopericarditis. But what we do is that we look at the ECGs to see if is there any ECG features suggestive of pericarditis. Sometimes myocarditis, their ECG can even be normal, right? So the diagnosis of myocarditis, it's made on cardiac MRI, and we do not take these patients for MRI because most of them, they are ventilated, they are in ICU. And also the mechanism of this myocarditis, it's thought to be multifactorial. One being that the COVID-19 virus is that it attaches to the angiotensin converting enzyme 2 receptors, of which the heart muscle possesses these receptors, and there could be direct toxicity to the myocytes, and this can induce apoptosis or accelerated cell death of these muscles. Then you get also inflammation of the myocyte, which will also drive this myocarditis. But also this fulminant sepsis that the patients have, and the cytokine storm, which is mainly inflammation that is happening, this uncontrolled inflammation may cause this this myocarditis, right? But then this myocarditis, then it also it possesses a risk to one developing life-threatening ventricular arrhythmias and also heart failure, right? Then another manifestation of this, it becomes a heart failure on these patients. The heart failure could either be from coronary artery disease, which is also a common presentation of these patients, because they come in either as a thrombotic coronary artery disease. They have typical chest pain. The ECG shows that they are having a myocardial infarction, and they are also COVID positive, or they have a pneumonia. Then they can have what they call type 1 myocardial infarction, which is a thrombotic myocardial infarction, where they will have a clot obstructing one of the main coronaries in the heart. And what has been reported, and what I think has been reported by some cardiologists in the country, is that as they do coronary angiogram on these patients, there's a large thrombus burden. The arteries have so much clot in this, and this could be because of the endothelial inflammation, because this is a systemic disease. They have endothelial inflammation, and also they are in a hypercoagulable state because of this virus, which is affecting all their vessels. But also what they get with these myocardial infarctions is that they have what we call a type 2 myocardial infarction, which is a demand supply mismatch, where now the heart is not getting enough blood to supply its own muscle. And this could be driven from patients when their blood pressures are too low in ICU, and they're in a cardiogenic shock, right?
Yeah.
Then there is also what we call a stress myocardial infarction, also known as Takotsubo myocardial infarction, where they have a non-obstructive, also is a type of a non-obstructive myocardial infarction. The heart is weak. They have ST elevation, which is in more than one territory of the coronaries, and the heart pumps very weak. But when you do a coronary angiogram, all the coronaries are normal. So
Yes.
cardiovascular manifestations there are multiple ones, and the big one that also has been noted is the thromboembolic disease, where the patients, they form clots, either the venous clots, and some, to a certain extent, also they form arterial thrombosis, but the venous clots were reported more than the arterial clots, where they end up with the pulmonary thromboembolic disease. And this is where patients now, they will shoot a clot to the lungs and obstruct one of the pulmonary arteries. Then there is a ventilation perfusion mismatch, and we struggle to ventilate this patient. The blood pressures, they drop because then the right ventricle is also under strain. And it then becomes a vicious cycle of a patient who is now having a cytokine storm, also septic, and now we are also struggling to give this patient now enough blood pressure.
Wow. So basically, Doc, you are saying as people, we must understand that this COVID-19 disease, as much as it's presented as a respiratory disease, is actually a multi-systemic disease. All right?
Yes. Yes.
All right?
Yes.
And basically, no system is spared of this. And within any system, there could be issues relating to the inflammation, relating to the immune response of the body, which sometimes can be exaggerated, which is the COVID storm, as we are talking about, and that can cause even more damage in the various tissues. But on the other hand, you can have a situation of a lot of clotting, again, linked to that COVID storm, which can actually block some of the critical, veins or arteries, and even lead to things like pulmonary embolus and stuff. So then you guys, you must be, I mean, when you have that patient coming in with COVID pneumonia, you crossing fingers, that, there isn't a lot, because to deal with that on the respiratory side and have to deal with these on the cardiac side, then it's touch and go.
Yes, and that's why, Doc, I tend to say I think COVID-19 is the most humbling disease that I think some of us would ever encounter in our lives, because then with many other diseases, if it's an anterior myocardial infarction, you get to the patient in time, you open up the artery, you're almost certain that this patient now is sorted. But with COVID-19 related diseases, no two patients present with similar, and the cause of the disease is different from each patient. And when you think that you have sorted something, then there's another system involved. That's why these patients, they need a multidisciplinary approach, and no one person can claim to know it all, to say, I know how to treat COVID-19 and all. It needs multidisciplinary. It needs people who are willing to say, I don't know what's happening. And I think as healthcare professionals, we need to accept when we don't know and ask for help.
Yeah, that's humbling. It's not a strength of medics to accept the limitations, even in terms of competence. But like you rightly say, I think it's a humbling disease, because even people who've been there, who are gurus in their own disciplines, they still struggle from time to time. And like you say, a multidisciplinary approach. Last year and early this year, I had an interview with Dr. Dube, Unomthandazo Dube, the neurosurgeon. And, one of the things when she came out of, ICU and she eventually was discharged, was to say the value of what we call allied professions, the physios, the OTs, the speech therapists, the psychologists, over and above the medical specialists that were looking after her. So I think there's more appreciation of what the different, professions within the healthcare team can bring to try and save lives and to rehabilitate people back to life. So now you are in Rustenburg. Are there no limitations for you there, when you want to do the best for your patients in terms of the infrastructure and everything?
I think the limitations are always there, and I think in every sector, especially the public sector, in every province, we've seen the limitation, and I think COVID-19 pandemic exposed the limitations that we have in the health sector. One being that of the facilities, two being that of human resource and skilled labor. And being in the Rustenburg area, the first limitation, look, I would say that in the private sector, coming in, starting a cardiology unit, it was easier. And the area already had a cardiothoracic. So the area already had a vascular surgeon. So we were able to run a cardiovascular unit in the private sector easily. The limitations were more in the government sector, but the government was willing to say, let's start something in here. What I find to be a limitation for many South Africans, it's not even about the doctors, it's the access to quality care by the patients, by the general population, by those people who come from the villages, by those who don't have access to medical insurance. So those are the people who are more disadvantaged. Yeah. But having said that, with the little that we have, we try to push the boundaries. And I think that there is more to be done. I mean, my feeling is that if each physician or each doctor in this country, when they see a patient in a day, if they choose one patient and they offer them the best available maximum efficient therapy in the country at that point, imagine how many lives we could save and how many lives we could change, because then if each of us can just take one patient a day and say, I'm going to do the best for this patient and the next one, and it will become a norm, and we keep on pushing boundaries, asking for more, especially in the government sector. I think we will create a good community and the best population ever.
Yes, yeah, I fully agree with you, Doc. Now, let's get to the issue of vaccination. All right, COVID-19 vaccination. Now, in South Africa, as at yesterday, we have vaccinated just over 6.3 million people. Obviously, the majority of those have had single jabs. Only a few, that is the older people, 60 plus, have had their second jabs. But at least as a country, we are now number 2 only to Morocco in terms of the vaccines, that have gone into people's shoulders. Morocco far ahead of us at 21 million, and we at 6.3. Now, the main vaccine that is being used in South Africa at this moment is the Pfizer vaccine, but there are also sectors that are getting the J&J vaccine, just like us as the medics. So there has been concerns that have emerged originally in Israel and then later in the US relating to certain cardiac adverse effects, especially on young men after they've taken the Pfizer vaccine. So, Doc, let me just give you space to just share a little bit about that. Is it something that people should be very concerned about, or is it, the risk of those things is even smaller than when you get the disease itself?
I think the data is there, the data speaks for itself. And the most important thing that we must clear out is that the vaccines have shown to be effective.
Yeah.
The vaccines are working. And what has been reported, the myocarditis that has been reported in a very small sample. And if you look at the numbers, is that it happens commonly in younger patients, younger than 50, and it happens after the second dose, where some patients developed myocarditis. But if you look at the myocarditis and the cause of the disease that these patients develop, is that they developed myocarditis. It was the cause of the disease, that they had a self-limiting episode of myocarditis. They had severe chest pain. Most of them did not even require admission. Those who required admission, they never required any circulatory support, either ventilation or to be on anitropes. Cardiologists looked at their hearts. None of them developed severe left ventricular dysfunction. In a worst case scenario, they developed mild left ventricular dysfunction, where they had an ejection fraction between 40 and 50%. But the benefits of the Pfizer vaccine, it far outweighs the risk that one will have that one will have vaccine-related myocarditis. Actually, you are likely to develop myocarditis from COVID-19 if you contract COVID-19 than from the vaccine. And you are likely to recover without needing any therapy if you had a vaccine-related myocarditis, as compared to where you have COVID-19 related myocarditis. That's when you most likely will need therapy, and that has been shown also to be a poor prognostic feature in patients that are in ICU. Yeah. So the bottom story is that it's less than, I think if you look at the numbers, it's less than 0.1% of patients who were vaccinated. I think they looked, the meta-analysis, they looked at about 300 million jabs that were given, and about 300 people were reported to have myocarditis, and this was confirmed on cardiac MRI, and there was no mortality reported on those patients, and they had a self-limiting disease. So again, the numbers are just too little for one to be concerned about.
Yeah. So essentially what we are saying is, like all medicines, or pharmaceutical products, there will always be side effects. But
definitely
in the medical space, when something is approved, to be used either as a vaccine or as a treatment, the benefits must outweigh the risks. And in this case, the benefits of vaccination far, far, far outweigh this risk. And what you're saying is that even those who happen to have myocarditis relating to the Pfizer vaccine, the overwhelming majority actually did not have anything major, and very few actually needed intensive interventions. And that risk is far lower than actually not vaccinating and getting COVID-19. So basically, in the bigger scheme of things, it's better to be vaccinated, than to actually not vaccinate. And I think it's important this, because there's a lot of vaccine hesitancy out there, and people hear these things without understanding the context. Same as the clots, the clotting in the brain relating to the J&J vaccines. Again, it was 6 people, out of 6 million people were vaccinated, and that becomes 0.0 whatever, which is actually lower than the risk of you getting the disease, the clotting when you've got the disease, or clotting from the contraceptives, that people normally take. So basically, it's important that things are put in the right context.
Sure.
Yeah. All right. Anything else that you want to say before we go to some of the people who have made comments? And the first person who has made a comment is Lebu, Dr. Patladira, and I want you to answer that question of his. But is there any things that you want to add around this matter of the vaccines and the risk on young men?
I think we should be, every physician should be advising their patients and the community to get vaccinated. And I think that we should be explaining to them this kind of information, because then this kind of information, when it gets to be put in the public media, then they might not be able to interpret it like we know how to interpret it. So it's important that we disseminate the information, the right information, and as physicians, we should act responsibility and have always look for evidence-based medicine. There is data that shows that these vaccines are working, and we are seeing that the numbers are not so much of those who have been vaccinated. We do not see many of them in ICUs. And yes, there will always be those rare cases, but we're sure that the vaccines are working.
Can I throw another curveball, Doc, before you answer the questions? Yes. There's the medical community is getting to be divided, because there are people who are pushing, and some of them, specialist physicians, who are recording videos and whatever, pushing for ivermectin and all of that. And I mean, so I just want your take. I know I did not ask you about this beforehand, but what's your take about the use of ivermectin as a preventative, drug, or even a drug to be used to treat those who have got COVID-19 disease? Just your take on that.
I think we must always be ethical, and as I said, evidence-based medicine. Medicine should not be thumbsuck or gut feeling to say, I feel like this drug will work and everything. Those who are saying ivermectin works, let them produce credible information and credible data that says ivermectin works, and let them present it to their peers, let them present it to the gurus in medicine, and let it be peer reviewed, let it be scrutinized. And if they so believe in this ivermectin or in this drug, that there's, let them produce their protocol, let them ask maybe the drug company to sponsor this, the trial, and let's see if it works.
And by the way, Roslyn, there's somewhere where it's actually becoming standard treatment. In one of the units, I'm not going to mention any names, and they will swear by it. There's a big regimen that includes ivermectin there, and yet these studies are not supporting that. I think it was the University of Columbia study a few months ago, and also an Argentina study that actually shows that there's no benefit at all. And those were, the randomized, double-blind, placebo-controlled, large studies that have shown that there's no benefit at all. If anything, there's a higher risk of hospitalization, more than the placebo group. So now, for the person out there who's not a medical doctor, they get confused because some doctors are saying this thing works, and they are recording videos and in the lay media pushing this thing. And yet, I would say the mainstream of doctors who are into evidence-based medicine, they're saying, no, this is quack medicine, basically.
Doc, I think we have authorities in this country and who control the drugs. We have the Health Professional Council who look at the conduct of doctors and everything. And in some instances, if this is given in a university, then the authorities of the university, the authorities of the hospital should go and scrutinize this kind of protocols, and they should be the ones acting. We shouldn't leave things to the public to decide for themselves. This is a space where the authorities must do their job and say, this stops or they approve it. Let's get the guidance from the authorities.
It is not the first time, though, Doc, from again Roslyn. You know, there was a late prof who was in charge of family medicine there. I used to argue with him a lot in the lay media, though, because he was a proxy of somebody very, very powerful who was pushing the denialist thing on ARVs. So it seems that there is a ground there that allows people to do things that are not necessarily evidence-based. But let's leave it. This is not about Roslyn. Let's get to the question from Dr. Patladira. Can you please answer that question?
Look, the question about the state of cardiology, I think it's a national problem. And also the COVID-19 has exposed that the discipline, we are very thin on the ground. There's very few of us. And I do not think that, I think we have now improved on the number of cardiologists we produce in a year. Yeah. But I think we need to produce more cardiologists in the country, and we need numbers, but we need numbers of people who are willing to work. It's simply unacceptable to have units which can go for 3 months not operating on patients. It's simply unacceptable. To answer Dr. Patladira, it's unacceptable. And again, there are authorities which are supposed to be auditing these units to say, but here you have a lab that is new. It's a lab that's supposed to work to serve a bigger population and a population of people who are deprived of so many things. Why should people wait for 2 months to have an angiogram done when you haven't done more than 50 angiograms a month? We should be questioning. And again, we have authorities who are running hospitals, who are running the provinces. They should be asking questions. And the population must start now complaining. We need to synthesize. We need to make sure that our population knows what's important. And we need to make sure that we offer our people quality care. We can't be giving our people the same treatment they were getting in 1986 for myocardial infarction, when now we have the facilities. So, Dr. Patladira, my answer is that it's saddening to know that some people in this country have to wait for such a long time to get cardiac evaluation, whereas we do have facilities that do not operate to the maximum of their potential.
Yeah. Okay. All right. All right. Thank you, Doc. Let me ask the lady who supports me, Nwabisa. I just want her to, ask a few questions that are coming from, the viewers on YouTube and Facebook.
Good afternoon, doctors. Okay, we have a couple of questions and comments. The first one is from Tabeleng Troy Malope. They asked jersey number. I think it was when we were speaking about sports. Also, we have another one from Dumelo. He wrote, from Santos FC, we sold him to Juve. Thank you for this session. This is a very inspirational doctor and always going for what he wants and believes in. We are really motivated. And a comment from Claudine, she wrote, she's tuned in. And another one from Tsekofatso Moshala. She wrote, and now all I want is to drive your beautiful RS3. And another comment from Julian William. He wrote, wow, what an inspiration. And a comment from Lamla and Mwata. She wrote, we are proud of you, young man. Keep doing the good work. And another one from Lindy. She wrote, an inspiration to juniors and seniors alike. Another one from Nobenguni Tlabati. She wrote, cardiologist and so young, last bonds are good people. And a comment from Lisifo Mawela. This is superb. Another one from Bulumko Matolweni. Well, he's introducing himself. Hi, I'm Langa Matolweni. And then Tabeleng Troy Malope wrote again, I can just imagine. And Tabiso Mailula wrote, in China, when Arsenal were promoted, they terrorized many experienced teams. Big ups to you guys at Jew for maintaining the legacy. Your career journey, though, is inspirational. Well done. And a comment from Hope. Kudos to Dr. Hadebe and Prof. Mohobo for their dedication in teaching. And a comment from Peter Siko, I'm watching. And Tabiso again, I love this in China. It's good to learn about your strategy towards a success in your discipline. And Tabiso again, I would love to learn how exactly you dealt with bullying as an intern. That's a question from him. And Melinda says, we're watching. And Tabilang again wrote, what makes a successful leader in a multidisciplinary environment like cardiology? And then another question from her, what jersey number did you wear at Juventus? And Ritabile Matolweni, it's a praise of hands emojis. Musa doing what he does best, a teacher at heart. And then Nobenguni Ntlabati, do patients also present with deranged liver enzymes, or is it because it's a multi-organ disease? And then a question from Ifra Duarte, can you treat the ventricular arrhythmias in myocarditis? Okay. And then a comment from Hope, COVID-19 is the most humbling condition indeed. And Salome from Mozo wrote, do people who just collapse and die without being tested for COVID-19 do post-mortem and also test for COVID-19? Okay. And then Tabiso again wrote, I salute you. It takes only greatness to acknowledge when something is beyond your competence. And then Tabeleng wrote again, wow, doctor, that's really humbling and amazing. Nobenguni wrote again, doctor, is there a way we can be advised about treatment? As he says, maximum efficient treatment for one patient. Neo wrote, yes, doc, so proud of you. Virginia wrote, can you comment on the link between Pfizer vaccine and myocarditis in younger patients? And a comment from Mandisa Boilani, amazing journey, Mmuso, Doc Mogwera. Thank you for sharing. The social cycle for Medusa is incredible. And Zanele, it's a praise hands emojis, multiple of them. And Zanele again, thumbs up or gut feeling. I love this way of explanation. And Joshua wrote, no questions, but well done to you, my brother. Salute Musa. And Tabileng says 100% agrees with you, Doc. And Danki Macaulay wrote, congratulations, great presentation. Esmeralda Mabena wrote, thanks, Doc, for that perspective. We need more professionals that are this passionate about their profession and the community. We have a couple, 3 more. Should I continue, Doc, or he would like to answer?
I think there's just too many. Hold them for now. But one question is coming from his friend, Dr. Patladira, and it's a quote on the Q&A. It says, running is dangerous, worse than having an extramarital affair. That was Chris Barnard who said that. The guy who was the first one to do a successful heart transplant. So the question from Dr. Patladira is, would you recommend an ECG post-COVID for runners and sportsmen?
Okay. I'm just going to try to break down this question. One is that the sportsmen should actually have their assessment, cardiac assessment,
Yeah.
irrespective of them having had COVID or not.
Yeah.
You will see in some of the European leagues and even UEFA, they have made an ECG, at least a basic resting ECG. It must be submitted when they are assessing their sports people. They even go to an.
And I think that could be important, Doc, because in the UEFA thingy that has just finished, on
Yes.
day one, we had Ericsson.
Yes. Who collapsed on the field.
Yes.
Yes. I think sports people, especially professional sports people, they should be assessed by a cardiologist or at least by a physician to have at least a basic standard ECG. Now, coming to post-COVID, let's remember COVID is a viral infection. Whenever you are having any viral infection, even including flu, we recommend that you should not be engaging in any sport until you recover. And upon your recovery, if you not as sports, you are not a professional sport person, upon your recovery, if you do not experience any symptoms, I do not see any reason why you shouldn't go back and do what you love, like exercising. But if before you can resume your exercises, you are experiencing some mild chest pain, you are experiencing any palpitation, or then at least consult your nearest GP. They will do your basic ECG, then they will interpret it for you, and they might, if they are worried, they will definitely refer you to the relevant people. So when you are ill, you are having pyrexia, do not try to exercise. There's this thing here, I will walk the flu out. You can't walk the flu out. You need to rest. Stay at home, rest, rehydrate. You can't walk the flu out.
Okay. Go to the other questions, Doc.
Okay. The other one, how did you deal with bullying during internship? I think one of the things that we we did, but what's important is that I think we must realize that sometimes the bullies, the problem is not you, the problem is them. They are dealing with their own inner demons. So they are just unhappy people and they just come to work and they are frustrated. It's unfair that they take out their frustrations out of them. And I would say to anyone who has been bullied to say, do not let them get to you. Focus on the end goal, but do not let them also make you a playground. There are areas that you can report them. If you feel bullied, you need to report them. You need to take some steps and report them, and there are review committees, there are authorities that will take steps against such people. It's just unacceptable for people to be bullied at a workplace or even during undergrad.
Yeah.
How do you maintain to be a successful leader? I think we learn every day. I don't think I'm a successful leader. Actually, I prefer leading from the back. I surround myself with people who are dreamers, people who set goals, and people who want to see themselves going somewhere and who are willing to encourage me. So I have acknowledged that I have my own deficiencies and I should not try to be knowing everything. So where I lack, I ask for help. Then Juventus, okay, yeah. Juventus, I was just number 8. Yes, I did play for Dr. Siko's Santos FC before I was convinced to join Juventus. And even there, it was still just number 8. Then there was a question about suspected COVID patients who collapse at home and everything. Look, I think if there's suspicion that there's someone who had COVID, then I think a bare minimum of a swab could be done. And if a postmortem is done, then the postmortem will be able to tell if there is any feature suggestive of COVID when they are looking at the lungs. And that's it. Then The last one, I think, maximum therapy, which I spoke about.
Yeah.
It is of my opinion that, especially cardiology patients, that we're not giving enough maximum therapy. I mean, the data is there. We have very few cardiologists. We are not doing as many heart transplant as one could, because then either we do not have the donor and we do not have the facilities. We still have many patients dying from acute coronary syndromes without even accessing the cath lab. One being that we do not have access to cath lab, two being that there is no one to operate in the cath lab, but sometimes the cath lab is just closed. So we are not monitoring who's supposed to be there and all that, especially in the public sector. So it is my view that if you are able to save one 50-year-old, offer them a rescue PCI on Sunday afternoon, even if it's a state hospital, that 50-year-old will go back and will contribute to the community. You would have saved someone's brother, someone's father. And I think the socio-economic impact of saving someone, definitely it will benefit many others. And I do not think in that area, I think we're lagging behind a lot. And it's time for many who are administrators to really have an introspection. And it's time for young people to really push the boundaries. And without distraction, we can push the boundaries without distraction. And we should be asking those who have been in the position to say, why are we not doing this? And what has been failing?
Youth League, Babuaka generational mix. We must bring in the young lions, I mean, fresh ideas. You can't be doing the same thing all the time and expect different answers. So it's about that the baton is actually handed over to competent young people with fresh ideas.
Yes, and that is where I was going with the maximum therapy, and I was looking at cardiology specifically, but I think in all the disciplines, if we can give our patients the latest and efficient, where there is evidence that this works, then our patients are going to be happy.
Yeah. Okay. All right, Doc. Just go in there. Your friend again, Dr. Patladira, has made a comment. It's more of a comment around advocacy and shaking things up, as far as the administrators are concerned. So I think just think about that. Nwabisa, how many questions are left? We need to finish now.
Okay. We have from Dr. F. Dube, well done, Mmuso. Keep up the good work. The future is bright. And Morao Seshali, great inspiration from this young son of the soil. Big up, Doc. And Duduzile Molife, keep up the good work, doctors. Obegang wrote, the very young and dedicated cardiologist who wants nothing but the best for his patients at all costs. You deserve a Hennessy. How to stand it in this lockdown, okay? And then there's the one from Sengitile Shongwe, well done. Odire Ledikwa wrote, you are such an inspiration, Doc. Thanks for always pushing us to put in our best and work smart. And Mandisa Boilane, thank you for the acknowledgement of the entire team, Doc. Albakov, wash hands, wash hands, wash hands. And Joshua again, BK wrote, I have no doubt that our family hearts are in safe hands. Luvuyo Bayeni, profound response on leadership question, and I have just learned something to apply in my leadership journey. Salome wrote, what is your take with regard to use of aspirin for COVID-19 pre and post? Esmeralda, are you seeing any rise in young stroke PTs due to COVID? Okay, we have 3 more. Solofelo Lehai wrote, very informative, and your journey is inspiring to the Black child. Thank you, Dr. Mogwera. Lebogang Mogwera wrote, very inspirational, well on your way to being the next Prof. Mohobo. And then we have a couple more. Should I continue, Doc?
Yeah, just
you
finish
can
so
continue.
that after
Okay.
this, you won't answer any questions.
Yeah.
All right. Ntabeleng Troy Molepe wrote, you are an inspiration and have offered great support. We really appreciate the difference you are making out there. Jersey number 8, may God continue to bless you. Dr. F. Dube, hi Mmuso, when is the PhD coming? And Novengoni Ntlabati, liver pathology with question marks there. And Virginia Mahabo, thanks for the informative presentation. My question has been answered. We are proud of you. You really are a motivation to the young colleagues. Continue shining. Roxy wrote, it's saddening that we have capable doctors and no resources. Okay, that one is written in Sutu. Our board, I'm not going to be able to read it now because it's written in Sutu. Sorry. All right, and then Luvuyo Bayene wrote, what is your advice on motivating young clinicians to be as patriotic? Yeah, that's it. Thank you so much.
Okay,
Thank you.
I think most of them, they were comments, but I will answer the first one, the use of aspirin in COVID. I think if you look at the pathophysiology that has been put forward is that there is endothelial dysfunction. And therefore, if there's endothelial dysfunction, aspirin will be very helpful in reducing the arterial or both the large vessel and small vessel thrombosis. So I think most units in this country, they will have aspirin as part of their protocol during the acute phase, and even post that they will advise the patients to continue on aspirin for some time. Then Dr. F. Dube, I want to assume that's Farai Dube. That was my senior. That's Farai Dube, very humble guy. He taught me a lot at Bara. When is the PhD coming? Look, it will come. One thing I realized is that I do not think I am ready for it now. Two is that when I do my PhD, I want to do a PhD in a topic that I will really love it and I will be really involved in it. I don't want to just do it for a matter of having a red gown. I want to do it in a way that it will change someone's life and it will change my cardiac patient's life. So it will come. Maybe when I celebrate my 40th birthday, I would be thinking of that. But for now, I'm enjoying to be a clinician. I'm enjoying treating my patients in the cath lab. And I think that's, for me, that's more than satisfying. It's not just a tick box. How do we go about motivating young people to stay in the country? I think we shouldn't underestimate the impact that we have to the young people and especially our interns, as I would regard it as their seniors now, because you do not even have to call a meeting to say, I'm trying to motivate you. By doing the right thing every day and by them seeing that this is how a patient came in and this is how the patient left, they get motivated. By you creating an environment where they are able to converse with you and tell you their obstacles and tell you their problems without them going through many hierarchies, by them being able to use your first name to say, Musa, can I talk to you? That's good enough to motivate them. The mistake that we make is that we want to put them in a hall. We want to bring some guy who doesn't understand the problems that they are facing every day, who's going to tell them about how they can drive an aeroplane without even having a car, a driver's license, a vehicle driver's license. But it's our actions that are going to motivate these people. And some of them, they get despondent and they leave the country because they are angry at our teachers, things that our teachers were doing to us. So again, it's all about each and every individual needs to do good from their small corner and brighten the corner and everyone will be happy.
Lovely, lovely, Doc. So Doc, as we wrap up, what's next for you? Already you've mentioned now that at some point the PhD is coming. And you know, I mean, that's a serious commitment, you know, to do a PhD. And I'm glad that you're saying you need to find a topic where you believe you will bring in new to the body of knowledge. You will bring in something new, and you are still looking for that area where you'll make the maximum impact in terms of, you know, the research that you'll be doing. So yeah, no pressure. But as long as at some point it does come. Also, what's next for you, Doc? Before we thank people for joining in.
I think my immediate goal now is to make sure that the Northwest, especially the Bojanala area, has a fully functional cardiac unit, and is to make sure that we no longer have patients who have to wake up at 5 o'clock just to go into Gauteng, to just be seen in Gauteng for cardiology assessment, and also to be operated in there. So the immediate goal is to try to convince another young cardiologist to join into the Northwest, to get a cardiothoracic to join into the Northwest, and to run a full functional cardiology department, and hopefully encourage as many young people as possible to join the cardiology.
All right. And when you eventually have to retire your stethoscope, age 75, 80 or whatever, you know, which is many, many decades from now, what would you want to be remembered for?
I would want to be.
What legacy would you like to?
Yeah.
To, obviously, you still have a long time to that point.
I would want to be remembered as the guy who brought medicine to the people, who brought cardiology to the people. I would want to have I would say, cardiac services without borders, irrespective of your socio-economic status. And if there's one thing, there's a legacy that I would want to leave, it will be that no one should ever feel inferior because they do not afford. And no one should receive inferior treatment because they do not have $1 million in the bank. So a guy who walks in a private hospital with a heart attack should be able, and a guy who walks in a public hospital, they should be able to be treated equally and have the same chances of survival. If I can achieve that, that for me is the legacy.
As a father now, to the little ones there at home, what would you want them to remember you for in terms of your career?
Look, one, I want them to remember me as a loving father. That's very important. Other than the career, I think there is more to life than just us chasing the publications, chasing the next ST elevation. So I want them to remember me as a loving father. But I would want them also to know that nothing is impossible in this planet. If you can dream it, technology will help you to achieve it. And no one should ever tell you that it cannot be done. I can tell you that if you ask anyone 2 years ago to say there will be cardiology services in the Rustenburg area, they will tell you that it cannot be done. It's happening. So they should go ahead, break the boundaries.
And then to wifey and to Ntate Mogwera.
I think also to my wife, I wanted to remember me as a loving husband and as someone who I appreciate all the support that she has given me, especially, I mean, during training, you need the maximum support that you can get from any side. And I think I wanted to remember me for that. And I want to be supportive to her and continue to be supportive. Hopefully and to make sure that she also achieves the best of her ability. She can perform to her best of her ability.
And to Ntate Mogwera, because you wrote a nice, you put a picture of his during the Father's Day.
No, that's my That's my man, aka Gueras. That's my man. I mean, that's the guy who motivates me a lot. I think to me, he has done more than enough. He did not have to push me to do things. All he did, he showed me the way and said, "Go. You are gonna have battles, and you are gonna fail. And when you fail, you need to get up and try again and try a different strategy." I am very thankful for to Gueras and the wife, and my mom, Queen. She's definitely a queen of my heart, and Gueras is my guy. Everything that I am because of those two.
Beautiful, Doc. On that note, I want to thank you, Doc, for affording us 1 hour, 45 minutes of your time. It was supposed to be an hour, but people just wanted to hear so much from you. So thank you very much for allowing us to have that 1 hour, 45 minutes of your time. And also thank you to, wifey at home, because this is quality time, family time, and to your boys, the young ones, thank you very much. And thank you to everybody who joined in, either here on Zoom or who followed via YouTube or Facebook. I think it's very important that we celebrate people like Mmuso. We really, really need to do that because, mainstream media doesn't always have time to recognize and acknowledge, people that are doing good. And so in our little way, we thought, by sharing Musa's story, it will also motivate somebody out there, and the kind of questions that we have fielded actually confirm that, we did the right thing. So thank you very much, Dr. Mogwera, and thank you to everybody who joined in. Until next time.
Thanks a lot, Fundi.
All right,
Thank you.
Bye.